right, so apparently it was time for choir practice here at 10 o'clock at night. Um, where were we? Alzheimer's. All right. At times, you may find the patient uncooperative, even combative, with biting, spitting, and punching. It may help to enlist the assistance of a caregiver the person trusts. Remember that the uncooperativeness and aggression are symptoms of the disease, not conscious acts that are acts of aggression towards you personally. Okay. Many geriatric patients who fall do not develop life threatening injuries but do not die from the fall. But certain injuries are common among those who fall. Make sure you assess for a hip fracture, head injuries, chest and abdominal injuries, spinal fractures, and fracture of the hands, wrist, and forearm or shoulder. All right, head injuries are harder to detect in geriatric patients. As mentioned previously, the brain shrinks in size during the aging process. Even though there is additional CSF surrounding the smaller brain, there is still more space in which the brain can swell or blood can accumulate in response to an injury. Treatment of geriatric trauma must be executed expeditiously. Provide spine motion restriction, precautions during the primary assessment if necessary. Administer high concentration of oxygen if poor perfusion is evident, and provide positive pressure ventilation if the patient breathes inadequately. Findings that support the field impression of a GI bleed in a geriatric patient includes hematochezia, all right, hematemesis, vomiting blood, hematochezia, red undigested blood and bowel movements, melena, dark tarry bowel movements indicative of digested blood. This means it came from above the stomach. All right. Indigestion, hepatomegalia, which is an enlarged liver, jaundice, yellowing of the sclera in the skin, indicative of liver problems, constipation or diarrhea, agitation, dizziness, inability to find a position of comfort. Your approach and assessment should be similar to any assessment format for the geriatric patient, focused on ensuring a patent airway and providing manual or mechanical airway assistance if the patient cannot protect their airway themselves, possibly because of a depressed mental status. If breathing is adequate, provide supplemental oxygen to maintain an SpO2 reading of 94% or greater. If breathing is inadequate, the oxygen should be provided via positive pressure ventilation. Treatment of the geriatric patient prone to hypothermia includes protecting the airway and maintaining normal breathing and circulatory status. Not only should you remove the patient from the cold environment, but you should also remove any wet clothing and insulate the patient in a dry blanket. Use caution when handling a severely hypothermic patient, as excessive handling or jarring movements can put the patient into a lethal heart rhythm. All right, geriatric neglect is the withholding of care by a provider of attention or medical care that the victim is entitled to. This type of neglect can occur passively or actively, the difference being that the intent of the care provider. With passive neglect, the failure is said to occur unintentionally and is often the result of care provider feeling overwhelmed by the needed task, or that the care provider simply does not know or understand the care or interventions that the patient needs. Okay, so this is something you need to pay special attention to going into assisted living facilities, nursing homes, even patients' homes. Okay. All right. Physical abuse of a geriatric person can also occur. All right. So, many indications that the EMT encounter, both physical and emotional, can point to abuse. Your primary role is to provide assessment and care for the patient. Do not try to investigate the suspicion of abuse or attempt to confront the alleged abuser. However, do report your findings or suspicions to the medical staff and provide thorough and objective documentation on your pre-hospital care report. All right, case study. Vic immediately stabilizes the cervical spine and performs a primary assessment. He notes that the patient's respiratory rate is about 24 per minute and shallow. She has a radial pulse of 88 and it is regular. The patient is agitated and cannot remember that Vic has explained what happened and what he is doing. Meanwhile, Tina places an oxygen mask on the patient. The engine crew has arrived and has prepared a long backboard. All right, what are some of the potential causes of altered mental status in this patient? All right, did she hit her head? Was she like this before? Did she have Alzheimer's, dementia? Is her blood sugar low? There's 1,000 things that could be wrong with this lady. Okay, what special considerations are there in spine motion restriction? Do y'all remember that kyphosis that we talked about? The curvature of the spine that you see in older individuals. And what additional assessment information do you need? All right. Always consider approaching the geriatric patient with the same degree of concern and consideration that you would show a pediatric patient. In addition, avoid any of the purposeful or accidental stereotyping of ageism. Ageism occurs when a person either unknowingly or knowingly discriminates against people who are old. Probably the two greatest social issues are isolation and marital status. With advanced age comes the loss of many friends and family near their own age. This isolates the geriatric patient from the rest of society as their social network decreases. One consistent feature of almost all living arrangements is that the EMT might be delayed in getting to the patient's side due to locked doors of care facilities, privacy gates in adult communities, or simply waiting for the patient's primary provider to arrive and give the patient's medical and physical history. Attempt to obtain as much as possible from the patient. Advanced directives are designed to express the patient's wishes as to the care they want to receive should they experience a significant change in their health. For example, a geriatric person with incurable cancer might have had an advance directive prepared on their behalf should they later experience another significant health crisis. Because the depth and the breadth of advanced directives vary from state to state, you must become familiar with how they are handled in your state and your EMS system. Because of the normal aging process, the response to illness is altered. Many medical problems present with different signs and symptoms in the geriatric patient than in the general population. For example, as we've already talked about, the lack of chest pain in a geriatric patient who experiences a heart attack is common. In general, the geriatric patient needs to be assessed and treated carefully. Any delay in recognizing healthcare needs and providing care can have devastating and irreversible consequences. When the geriatric patient shares living quarters or lives in an extended care facility, numerous patients can be victim to an environmental emergency. Determine whether any additional patients are present and call for additional resources if needed. All right, this is something we need to do during our scene size up. Although you might make a preliminary determination of the nature of the problem during the scene size up, maintain a high index of suspicion. Look for clues to chronic or acute conditions. All right, table 39.3 are some of the clues that you can pick up on. All right. The geriatric patient's mental status can be influenced by a chronic illness, the present illness or injury, prescription drugs they take, or a relative familiarity with their surroundings. The purpose of assessing the mental status is to determine a baseline level of consciousness and the possible need for airway protection and ventilatory assistance. It is important to ask family or caregivers to describe the patient's normal mental status. Okay, is this normal for them? When is the last time you saw them normal? All right, they're normally able to talk to you and tell you who they are, where they are, what year it is, what day it is, what city they live in, things like that, okay? Geriatric patients normally process information more slowly than their younger counterparts. The stress and confusion of an emergency can actually slow them down even more. Give them time to formulate a response to your questions rather than simply dismissing the failure to answer immediately as a form of altered mental status. Some of the other things that can cause altered mental status: dehydration, infection, those UTIs that we talked about, decreased or hyper or hypoglycemia, hypo or hyperthermia, drugs, alcohol, poor brain perfusion. Geriatric patients' gag reflex is diminished, which makes them vulnerable to aspiration of fluids and other food or solids, which can be fatal. Don't get a false sense of security if the geriatric patient rate starts to slow. False sense of the geriatric patient rate starts to slow. Okay. This can indicate respiratory failure rather than an improved oxygenation. If a geriatric patient suffers an acute respiratory distress, the muscles of respiration can fatigue and fall more rapidly than in a younger person. Okay? They don't compensate as well. They're tired. All right? Note any irregularity to the rhythm of the heart. This could be from the degenerative process that affects the conduction system, or it can be from drugs or prescription medicine, is what they're, for the most part, what they're referring to. Although street drugs, really wouldn't take that out of the mix either, that the patient may take. These are going to be your beta blockers, your calcium channel blockers. If they end in OL, that's a beta blocker. Prils are your calcium channel blockers, I believe. Okay. Note any irregularity to the rhythm of the heart. This could be, we talked about that. All right. The geriatric body does not display the same signs and symptoms as of dehydration as do younger patients, because the geriatric patient has overall a lower amount of body water, and because the changes in skin from aging, dry-looking skin can be normal. All right, we want to do that skin tiger. All right, pick up that floppy piece of skin on the top of their arm, on the top of their hand. Everybody has it. Sophie Jean, what are you doing? So, stop. Okay, and if it stays tinted up for greater than 2 seconds, then they are dehydrated. Okay. A geriatric patient who is alert and has an open airway, adequate breathing, signs of good peripheral perfusion, and a strong peripheral pulse is categorized as stable. A geriatric patient with an acute change in mental status, an obstructed airway, inadequate breathing, or signs of perfusion is categorized as unstable and needs immediate emergency care during the primary assessment. Any of these conditions is enough to place the patient in the unstable category. All right, when interviewing a geriatric patient, you might encounter characteristic challenges resulting from the general depression of the sensory organs. Okay, so how do we overcome this? You want to position yourself where the patient can see you, where you know they can hear you. Okay, make sure they have their hearing aids or their glasses. Okay. You can expect increased patient anxiety because of the inability to see surroundings, coupled with inability to exert control over the situation. You must talk calmly and be positioned so that the patient can best see you if they have any sight issues or hearing issues. Okay? Many geriatric people cannot hear high frequency or pitch speech, especially consonants. All right, obtaining a history can be difficult if the patient cannot understand your questions. Please do not assume that the patient is deaf without first inquiring with family or bystanders first. Please do not stand in front of these patients and yell and scream at them. You can write notes with them on a notepad, but please don't take their dignity away and just assume that they cannot hear you. Give them time, all right? Examine the head, neck, chest, abdomen, pelvis, body, and posterior body. Inspect and palpate for any kind of trauma. All right, the geriatric patient might not report everything that is going on. If you have some doubt about whether the patient can grasp what you are saying, you might want to make sure, subtly, of course, that a family member or bystander is also hearing and noting the same information. All right. While completing the secondary assessment, also assess and record vital signs and obtain a history from the patient if they are responsive or from the bystanders. All right. The systolic blood pressure, you want to look at their pupils. All right. Approach the geriatric patient with concern and compassion and talk to the patient about the emergency rather than talking about the patient to others. Okay. This can often make them feel isolated. This also allows you to gauge their mental status. Do they know who they are? Do they know what's going on? Okay. And unless they can't answer those questions, that's when that kind of gives you a little bit of liberty to talk to the bystanders and stuff. All right. But first, we want to address the patient. All right. And even though if they can't understand what you're saying, they can't get any information out to you, you still want to address them. Okay. They may completely understand what you're saying. You know what I mean? They may have what we call aphasia, where they can't talk. All right. If you have some doubt about whether the patient can grasp what you were saying, you might want to make sure that a family member or a bystander is also getting out of the conversation what you're getting. All right. You must distinguish signs and symptoms of chronic problems or natural aging processes, which can be very difficult to do without help from a family member or caregiver. Okay. So, the patient can become easily fatigued. Make sure that you are talking to them, explaining to them what you are doing before you do it. All right. Don't treat these people any other way than you would want somebody to treat your grandparents, your mom, your dad, your aunt, your uncle, if they were having an emergent situation. Okay. All right. You should anticipate the geriatric patient might not fully report all complaints. You should elect as much information as possible. Have you had a cough? Have you been peeing more than normal? Have you been peeing less than normal? Are you more thirsty? Are you more hungry? Any problems breathing? Any chest pain? Cough? Shortness of breath? Did you get dizzy and fall? Did you faint and fall? Did you trip over something and fall? How did you eventually end up on the ground? Any headaches lately? All right, stuff like that, okay? The geriatric patient is not set at ease when an unknown EMT arrives on the scene and talks to them as if they have been friends for years. It is inappropriate to address the geriatric patient by their first name or nickname and contributes to ageism stereotyping. The only exception is if the geriatric patient voluntarily tells you otherwise. To ensure appropriate care, reevaluate the geriatric patient frequently. The length of time spent with the patient or the condition of the patient can assist in establishing how often to repeat the reassessment phase. You want to repeat and record the reassessment at least every 15 minutes for a stable patient or every 5 minutes for an unstable patient. All right. Tina performs a rapid secondary assessment and is concerned to find crepitus depalpation over the patient's anterior chest. En route, the patient's vital signs are heart rate 96, irregular, respiratory 22 and shallow, blood pressure 128/88, and SpO2 88% with a non-rebreather mask at 15 liters per minute. Okay, so she fell, I'm assuming. I think that's what it said at the beginning. All right, and they find crepitus depalpation over the patient's anterior chest. So that's the front part of her chest. So her heart rate it's a little on the high side, but it's considered normal and irregular. That may be normal for her. We're not really sure. Respirations are 28 and shallow, and her SpO2 is 88% on a non-rebreather mask. Okay, let's think about this, all right? It's probably hurting like the dickens for her to breathe right now. So that may actually explain the respiratory rate of 28 and shallow and the SpO2, because she's not taking those full deep breaths like she normally would, okay? And right now her blood pressure is 128/88, so it's looking pretty good. The patient's mental status worsens, and she is more agitated and confused. Vic prepares to assist her ventilations with a BVM as Tina notifies the receiving facility. The patient is found to have multiple rib fractures and a pulmonary contusion. She is placed on a ventilator and admitted to critical care. Okay, so this goes back to that the ribs and stuff. All right, her SpO2 was 88 here. All right. She's not compensating with that 15 liters. This would be appropriate, especially with the respirations 22 and shallow. She's got crepitus over the ribs, all right? It would be appropriate here, especially since her mental status is getting worse. She's getting agitated and confused, probably because she's not getting that oxygen exchange that she needs. Okay, so it is very, very appropriate here to go ahead and bag this patient. All right, assist her ventilations. All right, so this was chapter 39. All right, this is actually the very, very end of our session here. And it has been a pleasure getting to lecture with y'all. Oh, and sorry about Gracie. She had choir practice at 10.